Again, as we said, diabetes is a progressive disease which is characterized by increasing insulin resistance and decreasing beta cell function over a period of time. At diagnosis, patients have already lost almost 50% of their beta cell capacity, and the ideal treatment strategy should provide continuity of the care as the disease progresses. So this is how the one drug is not enough. People need two, and then after sometimes three, and it goes on like that. So we have to have a flexibility to adapt the patient's need. That's what I was talking to you. So flexibility and continuity is needed when we are treating the people or with diabetes. This is the natural history where you have asymptomatic, where only the insulin resistance is there, and you have hyperinsulinemia, insulin production goes up, but there comes a time when insulin resistance is there, but the insulin production starts going down, and this is the time when you start seeing the rise in postprandial blood sugars, and then later on the fasting also goes down. And so before even the diabetes occurs, during impaired glucose tolerance phase, people are prone to get macrovascular complications, and people have microvascular complications for the diabetes, and the diabetes duration increases. You have more rise in fasting and postprandial, the endogenous insulin goes down, you have more of hepatic glucose output, insulin resistance remains, and this is how the micro complications they keep increasing. So we have to work here that initially we have to treat insulin resistance, and then the endogenous production goes down. They need multiple medications. After 10 to 15 years of duration of diabetes, most of the people they need insulin, maybe basal or maybe basal bolus, or multiple doses. So this is what I was talking. This is the year of the diagnosis. 0 year, you have already lost 50% of the beta cell function. No patient has lost beta cell function by 50%, and over a period of time, this goes on like that, and this is how they need more and more medications and more or insulin also needed in them. Multiple factors they play important role. One is genetic background. We always ask if we have pitaji ko hai, mother ko hai, if anybody SIBs having diabetes, and then we have hyperglycemia where the glucotoxicity plays important role. Even the people who have glucotoxicity and glucose is reduced, the blood sugar they start coming down. So multiple factors are important as far as diabetes is concerned, and we have the hyperglycemia, glucose toxicity. We have lipotoxicity because free fatty acids they go up, so that is also important. And with insulin or with medications, things they go down. So once you do one thing that reduce the glucotoxicity by any medication, other medication they start working. Lipotoxicity also goes down. There's amyloid deposition in beta cells and the protein glycation. So this is what we see. We see the glycated hemoglobin. In the same way, other proteins also they get glycated, and the people develop multiple complications of diabetes over a period of time. And these are the causes. Important here is this is the basics we are talking here. Initially, we used to say pancreas doesn't produce enough insulin, so impaired glucose secretion from the pancreas, and the glucose is not used or disposal is defective at peripheral level, that is at skeletal tissue as well as the adipose tissue, and there's a resistance of insulin or to insulin at liver level. This is how it produces more and more insulin. We call it hepatic glucose output. So insulin resistance plays an important role at insulin receptors. There are post-receptor defects also. This is how we have. So one side, you're having less of insulin and less of utilization of glucose in periphery and more production of glucose in the liver. And this is how the patient has increased plasma glucose level, or diabetes you call it. But now people started talking, there are more than these three factors. These three important: pancreas, beta cells, the muscle as well as adipose tissue, and the liver. Those three we used to talk. Now people have come out with multiple pathophysiological defects in type 2 diabetes, which give rise hyperglycemia. And we have these 8 defects. They call it ominous octet. This is Franjo, who has given this concept in 2009. And this is how he said you have defect in pancreatic beta cell, not only beta cell, alpha cells also defective. So this is how they produce more of glucagon. We have talked about increased hepatic glucose output, and they said there is a increased lipolysis as adipose tissue. There's an incretin defect in the gut. This is how people have started using incretin mimetics and increasing medication. And they say there's an increased reabsorption of glucose at kidney level. So people started using SGLT2 with the newer drugs, and this is decreased glucose output, uptake in the periphery, and the neurotransmitter defect is there. So patients they have psych is also defective. So we have ominous octet where you have the alpha beta cells, you have the periphery, you have the hepatic glucose output, you have the gut where incretin defect, you have the kidney where increased glucose absorption, you have the fat cell where the increased lipolysis, and you have the brain where neurotransmitter dysfunction is there. So all these 8 places, if you wish to treat diabetes properly, one has to see that we tackle all these places where the drugs may work. So they may have complementary actions, and then you can control hyperglycemia well. So American Diabetes, they said importance of controlling metabolic. So we have to control, as I told you, multiple factors, not only the glucose, that is A1C, but you have to see the blood pressure, you have to see lipids, you have to control the weight, and you have to, by doing all this, we may reduce microvascular complications as well as macrovascular complications. So this is where, so if this is the reduction, improve both